Good afternoon, everybody. My name is Isaiah, or Zay Smith, and today I am extremely excited and honored to be presenting my capstone project to you. The title is The Successful Implementation of an MRI-compatible ventilator for mechanically ventilated ICU patients at a small community hospital. And yes, I know it's a mouthful, but it was what I came up with. So, without further ado, let's get started. So, this has been a labor of love for me. It started about a year ago when I discovered the challenge, and this was that the hospital that I work at, St. Elizabeth Community Hospital, lacked an MRI-compatible ventilator. So this required us to transfer our ventilated patients out to one of our sister facilities, which was 36 miles one way. Um, the transfers, of course, as you can imagine, came with significant clinical and logistical drawbacks. Um, the cost was over $13,000 per transport. That included the fee that EMS would charge, plus the hours for the RT and the nurse to attend, and this would tie up our EMS service for anywhere from 3 to 5 hours because they would have to sit there in the parking lot at the other facility waiting for the scan to be done, which was not prioritized because the the patients at their facility took precedence. So there could be considerable delays, and this only increased the risk due to these delays and potential instability of the patient. So this slide outlines the initial challenge that we aimed to solve. So identifying the need, the transports didn't just cost a lot of money, they also impacted patient care. So during these transports, our EMS team would miss approximately, based on historical data, 2 emergency calls per hour that they were away during these transports. The 2 calls on average were about $6,800 a piece. On top of this, there was the emotional strain on the patients, the delay in the MRI imaging, and known risks of interhospital transfers, like potential tube dislodgement, barotrauma, all of these things. So it made it pretty clear that we needed an in-house solution. Our pre-implementation use was about 6 of these transports per year, and I did calculations based on all of the missed revenue, the cost for the transports themselves, the staffing hours, and based on 6 per year, we had over $365,000 in preventable costs annually. So our initiative had 4 core objectives: implement an MRI-compatible ventilator, eliminate the need for, or at least drastically reduce the need for these external transfers, improve safety and cost efficiency, and ensure standardized protocols throughout the multidisciplinary team. So this slide frames the strategic purpose behind our quality improvement initiative. In identifying our resources and barriers, the key resources included strong philanthropic support and a dedicated multidisciplinary team. We all wanted to see a change. We wanted something that was better for the patient and improve the workflow for staff. The barriers involved equipment costs, because as you all know, cost of a MRI-compatible ventilator is not cheap. The resistance to change was minimal, but it was still there, and coordinating with staff for training across all these departments involved. So we addressed these challenges through early collaboration, thoughtful planning, and structured dry runs to build staff confidence and buy-in. This initiative had far-reaching benefits. Families experience quicker diagnoses, which can in turn decrease length of stay, because some of the patients that, as a matter of fact, most of the patients that we were scanning brain MRIs were because of anoxic brain injury, so they were able to make decisions quicker. ICU patients accessed MRIs safely and without delay, and healthcare providers reported more streamlined collaboration, and we're starting to order this more now that the option was more readily available. So the initiative improved both patient outcomes and provider experiences across all departments. So the step-by-step implementation strategy, we began by securing philanthropic funding to purchase the ventilator. Every year there's a group called the Macaulay Circle that does a lot of fundraising, and they come up with a large sum of money that they then turn around and donate back to the hospital. But in order to choose which projects are funded, I had to pitch my idea to senior leadership in order to even begin to approach the philanthropy group. And then when that got approved, I was able to present to the group basically what I'm sharing here, the problem, that what it was costing our patients and staff, and then they voted to, based on available projects. Mine wasn't the only project voted upon, and so they agreed to fund my project. So they covered the full cost of the ventilator, which ended up being about $36,000. So then we developed the standard operating procedures and conducted the comprehensive cross-departmental training. I signed modules from Hamilton's website for both operating the ventilator and its use in the MRI suite. We did simulation drills where we transported over a voluntary patient across to our MRI scanner, because we don't even have one in-house. We have to transfer to our outpatient imaging center across the parking lot. So how was that going to look? The spacing in the MRI suite, So we made these dry runs and worked everything out. Involved our EMS partners who could stand by during these internal transports, because out in outpatient imaging, we weren't set up to run any type of codes in case of emergency situations. So we wanted to make sure that our patients were safe and the process was seamless. So now, on the back end of all of this, what our staff are saying, I've surveyed ICU nurses, the RT staff, radiology, and physicians after the implementation of this project. Prior to the project, 73% of my respondents rated the coordination of these MRIs as highly difficult. After implementation, 100% of the respondents reported that there was either a moderate or a significant improvement in the process, where 93% expressed the highest level of satisfaction. Staff described this new workflow as smoother and more supportive, and this led to a higher confidence in the level of care that we're able to provide here in our facility. The financial outcome, we saw a direct financial benefit, as you can imagine. Like I said, prior to implementation, these transports would be about $13,000 plus all the missed revenue during the time away, which led us to saving approximately $60,000 per case, and we projected 6 avoided transfers annually. Our return on investment surpassed this initial investment immediately, almost, well, yeah, actually, definitely, with the first transport. EMS availability improved because now, they're not pulled out of our county, sitting in a parking lot up at our sister facility, waiting for the scan to be done. They're actually here on site, able to answer emergency calls here in the community, and this has drastically reduced the lost revenue. So far, we implemented on September 13th of last year. That was our very first case on our own ventilator. And since then, we've done 8 of these transports now, because physicians are actually ordering them more now that we have the capability. So we are actually looking at about $487,000 in savings so far, and we are in May. So we have about 3 months more for our 1-year mark. So my hypothesis is that we're going to be saving well over $500,000 to $750,000 annually. So we evaluated our success using the Kirkpatrick Model. The reaction was that 93% of the staff were highly satisfied. Learning, 75% felt fully trained. The behavior was that interdepartmental coordination improved, and the results is that The initiative enhanced safety, eliminated transfers, and reduced cost. This structured evaluation validated the effectiveness of our strategy. And as you can imagine, we did encounter some challenges. There were some delays in securing the funding. There was workflow friction, some initial staff resistance, albeit minimal, and the MRI suite limitations. But each of these were addressed through strategic solutions like partnering with the philanthropy group, the dry run testing that we did, applying Cotter's change management model, and redesigning workflows to optimize our MRI space and the procedure. So looking ahead, as we focus on the future, our main focus is on sustaining the progress that we've made and in expanding this impact, the impact of this initiative. So we're going to maintain staff competency through annual training and simulation drills. By integrating the MRI transport protocols into hospital-wide emergency preparedness, we can further enhance safety. We will explore broader use cases in departments like the emergency department, and then we aim to share our success model with other rural hospitals in the system to support replication. And of course, we want to continue partnering with the Catherine McCauley Circle philanthropy group to fund future patient-centered innovation. So that's it. I would like to extend my sincere thanks to my department, the respiratory department, the radiology and ICU teams, and a special thank you to the Catherine McCauley Circle and Delcy Strahan. She's the manager of philanthropy that helped organize all of the interaction between myself and the Catherine McCauley Circle, just for their generous support. And then a special thank you to Heather Esparza for her mentorship. This project, like I said, was a true labor of love for me. It was extremely fun and rewarding, and a true team effort. So just thank you to everyone involved. These are my references that helped support the development, implementation, and evaluation of the project. And thank you for listening.